Welcome everyone to our case-based presentation, Cardiac Symptoms and Risk in the Postpartum Period, What Not to Miss. This is a CME that's sponsored by the Women's Health, Cardiovascular, and Primary Care Service Lines, and we're really excited to be hosting this CME today, so thank you for joining. Just a couple of housekeeping items before we get started. This is the CME code. You can submit it via one of the following options. You can text it, use this website, or use the app that's here. And you have to create a profile in order to receive credit, which I think most people are familiar with. And the institution code is UPenn. And also as a reminder, probably about 30 minutes ago, everyone that's registered to participate in the CME received a survey. So if you could, it just takes probably a minute or two. If you could fill that out, we would love to do a pre-assessment prior to the CME, and we thank you in advance. And then the only other thing I'll mention is we got some great questions in advance. If people have questions during the presentations, please put them in the Q&A, and I'll be monitoring the Q&A, and we'll get to as many questions as we can at the end of the presentations. And if there are questions that we don't get to, we will try to, in follow-up to the CME, we'll send out a recording, but also we'll try to answer some questions that way, and also we'll send some summary of some of the highlights of pearls from this presentation afterwards as follow-up with the recording. So with that, I want to thank you all again for joining us. And what I wanted to start out with for just a couple of minutes is some background on this topic and how we came to picking this topic for today's CME. As people know, and I'm sure I've seen in the news over many years, we're in a kind of state of maternal health crisis. Maternal mortality and morbidity rates have been rising. And these are some sort of snapshots from some of the articles that have been in the news over, the last 3 to 5 years or so. And there's been significant disparities that we've noted and continue to see in maternal mortality and morbidity. And what this raises is sort of the issue of when I think people hear about maternal mortality who are not OBGYN, it's not really clear what the impact is of non-OBGYN providers are in the area of maternal mortality. Sort of, it impacts us all from a societal perspective, but from a provider or a nursing perspective in fields that are not OBGYN, I don't know that it's always clear kind of some of the epidemiology around maternal morbidity and mortality, and how this isn't just a pregnancy problem or a problem in pregnancy. It actually very much spans the postpartum time period and the time period when many of us, OBGYNs included, but primary care doctors, emergency medicine doctors, nurses in all of these different spaces have an opportunity to impact the maternal mortality rates and the disparities that we're seeing. And so our hope today is to sort of share the ways in which we all kind of can work together to really reduce maternal mortality rates and disparities in this country. And so the first question is always about the timing. So I think when people hear maternal mortality, they think in pregnancy or at the time of delivery. And while a lot of some mortality happens in that time frame, and this is a paper that is a summary from 14 maternal mortality review committees in 14 different states that the CDC published. And it just shows you that actually like 60% of mortality actually happens postpartum. And about 50% of it is happening after patients are discharged from the hospital. And even, further out, as you can see, through that 1 year postpartum. And so that's sometimes surprising to people to know that mortality is really a significant proportion still is happening actually beyond the traditional time period that we think of in terms of during pregnancy or immediately kind of after delivery. The second thing I think that's surprising and how we came to this topic is, what are the causes of pregnancy-related death? And that's particularly deaths that are due to pregnancy or were exacerbated by pregnancy. And you can see in red in this bar graph that they're all, those are all the cardiac-related causes of deaths. And there's a number of them. And this is also from the CDC pregnancy mortality surveillance system. So you can see that there's several cardiac-related contributions to maternal mortality, and hence the sort of choice of really coming together as multiple service lines to really bring this educational session to all of you. And while I know many of us that are on the CME were from across the system, and we're really excited to have everyone joining us from across the health system, wanted to just highlight some things that have been noticed in Philadelphia and how they mirror what's seen nationally in the data that I just showed you. Philadelphia and Penn Medicine, we do 9,000 deliveries, which is the majority, a high proportion of the deliveries in the city of Philadelphia. There's been a city-based mortality review for over a decade. And we've noticed that in pregnancy-related deaths in these reviews, that 46% of them are related to cardiomyopathies or other cardiovascular causes. And those disparities that I noted previously in our introduction are very much seen in Philadelphia, just like they are seen across the country. And those figures at the bottom there show the causes of death for pregnancy-related death. This is from a Philadelphia maternal mortality report that was published in 2020. So mirroring sort of what you saw in that national bar graph in terms of causes, cardiovascular being among the top. And the timing also showing you that in Philadelphia, it's the same as what we're seeing kind of nationally, which is that a large proportion are happening in the post-delivery or postpartum timeframe. So from this report, there were several recommendations, and one of which in Philadelphia, but sort of more broadly, and this is sort of mirroring kind of recommendations and things that are activity that's happening nationally, is really to heighten the awareness of high-risk pregnancy and postpartum complications in non-obstetric care settings. And in Philadelphia itself, there's a Philadelphia CARDS OB task force that's directed by one of the Penn maternal fetal medicine attendings, one of my colleagues, Dr. Lisa Levine, is really looking to sort of implement and evaluate a cardiac risk algorithm for when patients present in these non-obstetric settings, in particular with cardiac complaints. So more to come on that, but Philadelphia itself has a significant lens on this issue, and this issue is also being kind of looked at through partnerships with our national professional organizations like the AHA and like the ACC and the American College of OBGYN as well. So this is sort of a timely topic and one that we hope will be very informative to all of you participating. So these are our learning objectives for today that you received when you registered. So we're excited to kind of get to our two presenters today. And here are our two speakers. Dr. Louie is an assistant professor of medicine and the director and co-director of the Pregnancy and Heart Disease Program. Her research really focuses on identifying optimal strategies to reduce cardiovascular risk during pregnancy and postpartum, and reducing racial disparities in maternal cardiovascular health. And then Dr. Monica Sangavi is the director of women's cardiovascular health at Pennsylvania Hospital. And she's a non-invasive cardiologist who works at Hupp and Penn and is the director of women's cardiovascular health there, as we said. And her clinical focus is on women's cardiovascular disease and prevention. And she also serves as the vice chair of the National AHA Women in Cardiology Committee. So I want to thank both of them for doing this CME with us today, and I will turn it over to them.
Great, thank you, Cindy. I'm just going to go ahead and share my slides. Okay, thank you for the introduction, and thank you to everyone who's joining us today. I know that we have a diverse audience across the health system, and excited to talk about this, increase awareness, and to hear your questions and hopefully answer them. I have no conflicts of interest to disclose. So the objectives for this talk are to review the leading causes of pregnancy-associated mortality in the US, which Cindy already alluded to, understand the diagnosis and early treatment of peripartum cardiomyopathy, review the causes and evaluation of chest pain in the postpartum period, and hopefully to improve confidence in screening for postpartum cardiac complications. As Cindy pointed out, cardiovascular disease is the leading cause of pregnancy-related deaths in the US, which are deaths during pregnancy or the first year postpartum. But when we look at just the postpartum period, cardiomyopathy is the leading cause of death, and the majority of these cases are due to peripartum cardiomyopathy. A few additional facts about maternal mortality that is relevant to all of us is that half of maternal deaths occur after delivery and after hospital discharge. So these patients are presenting to the emergency room, to primary care, to urgent care. They may or may not be in contact with their OB providers. 60% of cardiovascular deaths are considered preventable, and most individuals who die from cardiovascular disease postpartum do not have a prior diagnosis of cardiovascular disease. And I think it's also important to point out that although the data on maternal mortality is critically important and compelling, it does not capture the high burden of maternal morbidity as well. In terms of racial disparities, we know that they are present and severe, and that Black women are 3 times more likely to die than white women from pregnancy-related causes. And specifically, when we look at different causes of maternal deaths, the greatest disparities for Black women exist for deaths due to cardiomyopathy, preeclampsia and eclampsia, and venous thromboembolic disease. So I'm just going to jump in and start with a case. Case 1 is a 30-year-old woman who is presenting with dyspnea on exertion for 1 week. She also has dry cough, orthopnea, and some mild leg swelling, asymmetric leg swelling. She has a history notable for hypertension, sleep apnea, not using CPAP, obesity. Her BMI is 60, and she is an active tobacco smoker. On presentation to the emergency department, she is hypertensive, she's tachycardic, her O2 sat is 98% on 2 liters. She has increased work of breathing at rest. She has wheezing on exam and faint bibasilar crackles. Her GVP was not well visualized. She did not have obvious murmurs, and her extremities were warm, and she did have left greater than right lower extremity edema. And so what's missing in this history? And what's missing is her OB history. And I bring this up because the CDC, in their campaign to increase awareness of complications during pregnancy and postpartum, highlights that many clinicians do not know that their patients may be postpartum, and the importance of asking. You can imagine that a patient who delivered a few days ago, a few weeks ago would bring this up as relevant, but what about someone who delivered 1 month, 3 months, 6 months ago? It may not spontaneously come up in conversation. And so I just emphasize the importance of all of us getting a pregnancy history for a variety of reasons. And so for this woman, she's been pregnant 4 times and has delivered twice. Her last delivery was 6 weeks prior. She had a full term delivery, cesarean section, and she did not have pregnancy complications separate from her medical conditions, and she is not currently breastfeeding. Top of the differential diagnosis for this patient in the emergency room, and I think appropriately, was pulmonary embolism. And she did have a CTA of her chest, which showed no PE, but she did have extensive patchy and nodular opacities concerning for pneumonia. And I think this case is very salient to me because I think in some settings, this is probably the extent of her workup. She would have been treated with antibiotics and potentially discharged from the emergency room, but it was not the end of her workup. She had labs drawn, and notably her NT-pro and BNP level was greater than 4,000, which led to a bedside echo, and then a formal echo, which showed that her LV was severely dilated, her EF was about 20%, and she also had hypokinesis of her right ventricle, consistent with a diagnosis of peripartum cardiomyopathy. Many of you may be familiar with the criteria for defining peripartum cardiomyopathy, but it includes new onset heart failure with an EF less than 45%. It's diagnosed towards the end of pregnancy or in the months following delivery, and it occurs without pre-existing heart disease. The reference I put up here are the 2018 European Society of Cardiology guidelines for the management of cardiovascular diseases during pregnancy. A very helpful resource, very easy to read for all of you in the audience. Major risk factors for peripartum cardiomyopathy include older maternal age, Black race, so it's more common in Black women than in white women, and the reason for that is not entirely clear. Twin gestation and preeclampsia. So interestingly, overall, the prevalence of preeclampsia is 3 to 5% in the US, whereas over 20% of women with peripartum cardiomyopathy have preeclampsia. The schematic at the bottom highlights the fact that preeclampsia can lead to subclinical cardiac dysfunction, which Dr. Sangvi will be talking about next. These patients have a normal EF and are increased risk for long-term cardiovascular disease. A much, much smaller subset of women with preeclampsia will develop peripartum cardiomyopathy. The good news is that most women, 65 to 70%, will fully recover. However, predictors of poor recovery are having a severely decreased EF at the time of diagnosis, having a severely dilated LV, being of Black race, and having a delayed diagnosis, so greater than 1 month postpartum. You can see here the recovery by race and baseline EF, and it's important to note that 15% will have serious adverse outcomes, including death, need for LVAD or heart transplant, or severe persistent cardiomyopathy. I also wanted to highlight, using the data that we have here at Penn, the timing of diagnosis. So diagnosis most often occurs within a month after delivery, but can occur 6 months or more postpartum. Again, getting at the importance of asking about the OB history. And what we showed in our data, which is consistent with other studies, is that Black women are diagnosed later in the postpartum period. As you can see in this, this figure, non-Black women are diagnosed, half of them are diagnosed within a week of delivery, whereas Black women are diagnosed throughout the postpartum period, and early diagnosis is associated with a twofold higher odds of recovery. Delayed diagnosis largely occurs when symptoms are not recognized or promptly evaluated. It is possible that some women do not develop symptoms until much later in the postpartum period. And I certainly have patients who very clearly say they felt well, they were exercising until 2 months or 3 months postpartum, and then their symptoms started suddenly. But I have seen more patients who have been diagnosed with new onset asthma in the postpartum period, have received several courses of antibiotics without a cardiac evaluation. For example, this past year, I met a woman who was 26 years old. In her first pregnancy, she developed gestational hypertension, had some worsening shortness of breath and edema during her 3rd trimester. She developed severe preeclampsia, was induced at 36 weeks, discharged on nifedipine for blood pressure. And then postpartum, she initially had some mild dyspnea, but it progressed. So she had difficulty walking upstairs. She was sleeping in a recliner. She saw her postpartum provider several times. She was referred to a pulmonologist and for PFTs. At 5 months postpartum, she had a chest CT for a completely separate reason, and that incidentally found cardiomegaly and pleural effusions. And so after this, she was referred to cardiology, and her echo showed an EF of 15 to 20%. She felt immediately better with diuresis, but her EF is still low, and her odds of recovery are lower given her delayed diagnosis, dilated LV, and low EF. The medical treatment for peripartum cardiomyopathy is early goal-directed medical therapy, with this table here showing that even for postpartum breastfeeding women, they can be started on many of the medications that we use for goal-directed medical therapy. And I just wanted to highlight that there may be a role for medication called bromocriptine, which is a dopamine agonist, which inhibits prolactin release. There's equipoise about whether this is effective or not, and there is a nationwide RCT, and we will be enrolling women at Penn, probably starting within the next few months, who are interested in being in this study. I do want to highlight that BNP levels can help evaluate for heart failure both during pregnancy and postpartum. This is really important. So BNP levels are higher in pregnancy, but still within the normal range. They are higher in preeclampsia and may be associated with subclinical cardiac dysfunction, and there may be a spike in BNP in the very early postpartum period in the first few days after delivery. That being said, in a study of women with cardiac disease who had serial BNP levels drawn throughout pregnancy, a normal BNP level had 100% negative predictive value for a cardiac event. And I would say that an elevated, I said very elevated here, but really any elevated BNP level should raise suspicion for heart failure during pregnancy or postpartum. In some cases, those patients, may have preeclampsia, but if they have preeclampsia and shortness of breath, perhaps a cardiac evaluation is warranted. Okay, moving on to case 2 is a 35-year-old woman who is 2 weeks status post full-term vaginal delivery. She has no past medical history, no cardiovascular family history. She's a non-smoker. She's had 4 pregnancies and 4 deliveries, no pregnancy complications. She is coming in because she had chest pressure lasting 20 minutes while sitting on the couch associated with some diaphoresis and nausea. And then it recurred overnight and woke her from sleep and lasted a little bit longer. The differential for chest pain after delivery is similar to our differential for chest pain in a non-pregnant or postpartum individual, with the sort of increased knowledge that the risk for PE, acute coronary syndrome, and aortic dissection is increased in the early postpartum period. Her EKG is shown here, and as you can see, she has deep T-wave inversions in the anterolateral leads and poor R-wave progression concerning for anterolateral ischemia. On arrival, her troponin was negative and it steadily increased overnight. And in the setting of this, she was sent for cardiac catheterization, which showed a spontaneous coronary artery dissection involving her entire LAD. The white arrows here show that there's severe narrowing of the proximal LAD and a diagonal branch, and the red arrows show where there should be the mid to distal LAD, but there is in fact no flow. Spontaneous coronary artery dissection occurs when there is a hematoma that forms within the wall of the coronary artery, and it compresses the true lumen and decreases myocardial blood flow. And in some cases, the intramural hematoma can lead to increased pressure and actually cause an intimal tear, with the progression of the intramural hematoma and intimal tear shown on the right. SCAD is an important cause of acute coronary syndrome in younger women and is diagnosed on cardiac catheterization. I bring this up because the questions sometimes come up about whether we can diagnose SCAD by CTA of the coronaries. And the point is that we may be able to see dissection on a coronary CTA, but we may not be able to see dissection. And that's because sometimes the dissection is in the distal vessel or in a smaller vessel, and so it just may be difficult to visualize. So cardiac cath is the gold standard. A few points about SCAD in general, since I realize not all of you may see this on a regular basis, is that 9 out of 10 patients with SCAD are women. The mean age is 48 years. Traditional cardiovascular risk factors are not usually present, and pregnancy is a heightened risk state. So as you can see here, of all pregnant and postpartum women presenting with acute coronary syndrome, up to 43% of them will be from SCAD. Pregnancy-associated MI is luckily uncommon, but it may be underdiagnosed. And I do want to make the point that SCAD in the pregnant and postpartum period tends to be more severe than SCAD that does not occur related to pregnancy. And so these pregnant postpartum women are more likely to present with STEMI, multi-vessel involvement, proximal vessel involvement. The majority of cases of SCAD occur postpartum, especially in the first week or the first few weeks after delivery. In general, our treatment of SCAD is medical management when feasible, and that's because stenting may be high risk. There's a higher risk of PCI failure. So CABG may be appropriate for certain high-risk cases. The other reason we pursue conservative management is that healing occurs in the majority of cases within weeks to months. And so medical therapy includes aspirin, sometimes Plavix, beta blockers, anti-anginal medications, and then further evaluation includes mental health assessment, referral to cardiac rehab, and then screening for other vascular disease. Also important to point out that postpartum individuals can have MI from atherosclerosis or other causes. In this case, this was a 36-year-old woman who had hypertension, high cholesterol, and a family history of early coronary disease. She was G1P1, 3 months postpartum and breastfeeding when she developed exertional chest pain, which was escalating and then started to occur at rest. On her labs, on presentation, her troponin was negative. Notably, her LDL was 181, and on cardiac cath, she had a severe obstruction in her mid-LAD, which was treated with a stent. And in this setting, this was someone who had previously undiagnosed familial hypercholesterolemia, underscoring the importance of cardiovascular risk screening in the pre-pregnancy, pregnancy, and postpartum period. Okay, so case 3 is a woman presenting with shortness of breath and chest pain postpartum. This is a 36-year-old woman who is 5 days status post-vaginal delivery. She has a history of asthma on inhalers. She is a G6P4 and was actually induced at 34 weeks for severe preeclampsia and discharged on amlodipine. She also had a postpartum hemorrhage requiring transfusion. She's presenting with dyspnea, squeezing chest pain, palpitations, and lightheadedness. And on exam, she's tachycardic, normal blood pressure and O2 sat, and her labs reveal a negative troponin and an NT-pro and BPET level that is the upper limit of normal. And her EKG shown here shows largely sinus tachycardia and nonspecific T-wave changes. And so similar to some of our other patients, she also had a CTA chest to evaluate for PE, and in fact, she did have a PE. A few notes about pulmonary embolism in the postpartum period. So the incidence this is for venous thromboembolic disease, so DVT or PE is listed here, but it's important to note that the risk increases throughout pregnancy, but the highest risk is actually in the weeks after delivery. D-dimer levels increase throughout pregnancy and cannot be reliably used to assess for PE. The risk factors as listed here is a prior history of thrombosis, a history of thrombophilia, older age, C-section, and obesity. And symptoms include, symptoms are actually similar to PE that occurs not in pregnancy or postpartum, which are dyspnea, pleuritic chest pain, cough, and hemoptysis. I just wanted to highlight the case of Serena Williams, who has spoken and written about her experience of having a PE postpartum, despite having a history of PE and developing similar symptoms immediately after she gave birth to her daughter. She felt like her concerns were not heard by her medical providers, really underscoring the importance of listening to our patients and realizing how this can contribute to racial disparities in maternal cardiovascular health. Other cardiovascular diseases in the postpartum period. So aortic dissection, again, rare, but an 8-fold increased risk compared to non-pregnant individuals. Aortic dissection is more common in women who have connective tissue disease, such as Marfan syndrome, and to a lesser degree in women with hypertension. And the important thing to note is that almost half of women who have an aortic dissection associated with connective tissue disease do not know that they have connective tissue disease prior to their dissection. So again, the importance of evaluating people prior to pregnancy for medical comorbidities. And then other causes of cardiovascular disease in the postpartum period include cardiomyopathies that are not peripartum cardiomyopathy, so pre-existing cardiomyopathies, which may or may not be diagnosed prior to pregnancy, arrhythmias and sudden cardiac death, valvular heart disease, congenital heart disease, pulmonary hypertension. As you can imagine, for some of these conditions, exacerbation of symptoms are more likely to occur in the 3rd trimester when women are at peak circulating plasma volume, increased stroke volume, increased heart rate, and that higher volume load of pregnancy can often lead to new symptoms of heart failure. You know, one of the questions that came up beforehand and often comes up amongst the clinicians who take care of this population is, how do we differentiate cardiac symptoms in pregnancy and the postpartum period separate from the normal symptoms of pregnancy? And what I would say is it's tough. It can be very difficult. Shortness of breath, very common in pregnancy. But some of the red flags that I listed here may be able to help. So dyspnea at rest is unusual. I often ask for women who've been pregnant before, does this feel significantly worse than their prior pregnancies? For people who are able to easily climb a flight of stairs prior to pregnancy, do you now need to stop to catch your breath before reaching the top of a flight of stairs? And then for postpartum women, looking at dyspnea that does not improve or is getting worse after delivery, that would be another red flag. Associated symptoms such as orthopnea, edema, or cough, these can be tricky during pregnancy, especially orthopnea. Women may be sleeping propped up for a variety of reasons unrelated to their breathing, but really trying to get at if it's, are they sleeping in a recliner? Are they sleeping upright because it's hard for them to breathe? Edema can sometimes get worse in the days or week after delivery. However, it should not be getting worse in the several weeks following delivery. And then objectively observing increased work of breathing, increased respiratory rate, or low O2 sat. For chest pain, I wanted to make the point that for a lot of, I think in the media, there's a lot of discussion about how women presenting with a heart attack often have different symptoms than men. But actually what we know is that the most common symptom for women and men is chest discomfort. Some people might not call it pain, they might call it discomfort or pressure or squeezing, but it is chest discomfort. Exertional chest pain that improves with rest is highly concerning for angina. Sudden chest pain at rest lasting more than 5 to 10 minutes, especially if it's associated with other symptoms such as feeling unwell, diaphoresis, or nausea, and then escalating symptoms that eventually occur, waking someone from sleep would also be concerning. Many pregnant women have experienced heartburn, so asking, is this different from your heartburn symptoms, can be helpful. And I think the other thing that comes up, especially in the postpartum period, is the role of anxiety. And anxiety can cause chest pain, but also people who have chest pain, that causes anxiety as well. And this can be very difficult to differentiate the two. And so I think especially if there are any associated symptoms, if you feel like something isn't right, and especially if the patient feels like something is not right with her body, I think it's important to do a cardiac evaluation. I did want to highlight the Hear Her Concerns campaign by the CDC, which underscores the importance of individuals, pregnant and postpartum individuals, talking to their care providers about any new symptoms that they develop during pregnancy or the postpartum period. And so my hope is that this reaches a wide audience and that maybe patients will even be bringing in, this checklist or this guide to help start the conversation when they're feeling unwell. And so this is my summary of what we talked about today, the 3 C's of postpartum cardiac symptoms: clot, cardiomyopathy, and coronary syndrome, which are the 3 things we don't want to miss in the postpartum period. Quickly, just wrapping up, resources at Penn and our Women's Cardiovascular Health Program. We have a number of providers, myself and Monica included, also Marietta Ambrose and Sharon Rubin, who see patients here at HUP and at Pennsylvania Hospital. We have a combined cardiology MFM clinic once a month for women with pre-existing heart disease or in need of preconception counseling. And you're always welcome to call us with questions or help with triage. So in conclusion, cardiomyopathy is the leading cause of maternal deaths postpartum. Do not diagnose new asthma postpartum until cardiac causes have been excluded. BNP is a helpful tool to diagnose heart failure in peripartum individuals, and certainly echoes work well too. Abnormal EKG and positive troponin is acute coronary syndrome until proven otherwise. And then finally, SCAD is a common cause of acute coronary syndrome postpartum and is diagnosed by cardiac catheterization. So thank you so much.
Awesome. Thank you so much, Dr. Lee, for taking us through some of the major causes of cardiac morbidity and mortality in the postpartum period. And I'm going to pivot now and talk about postpartum cardiac risk assessment and risk factor modification in women with adverse pregnancy outcomes. I have no disclosures, and my goal today is to define adverse pregnancy outcomes, discuss long-term cardiovascular risk associated with these adverse pregnancy outcomes, as well as explain age-appropriate cardiovascular risk assessment and risk factor modification. So when you're looking from the lens of a cardiologist or cardiovascular disease, we think of 4 main adverse pregnancy outcomes. These include hypertensive disorders of pregnancy, gestational diabetes, preterm birth, and small for gestational age infant. Within hypertensive disorders of pregnancy, if you recall, it is a spectrum of diseases ranging from gestational hypertension to preeclampsia to eclampsia and HELP syndrome. And even within preeclampsia, there are several subcategories, include severe preeclampsia, as well as superimposed preeclampsia, which happens when preeclampsia is superimposed on chronic hypertension. I want to remind everyone that we use the 20-week gestation mark to differentiate between hypertensive disorders of pregnancy and an underlying chronic condition that is manifesting in pregnancy. So if the hypertension occurs after 20 weeks, we think of it more of a hypertensive disorder of pregnancy. I'm going to use this hypertensive disorders of pregnancy as a prototype to discuss future cardiovascular risk in these women. So if you think, most of you are probably aware now that preeclampsia is associated with increased cardiovascular risk. And this includes about a twofold increased risk of atrial fibrillation, stroke, coronary heart disease, and cardiovascular death, and almost a fourfold increased risk in heart failure. Not only does the severity of the disease matter, but also the timing of the disease. Women who have really preterm preeclampsia before 34 weeks have a much higher risk of dying from cardiovascular disease long-term than women who have preeclampsia later in their pregnancy. So severity and timing of disease all matter when we're talking about long-term cardiovascular risk. Not only are these women at higher risk for long-term cardiovascular disease that we've talked about, but they are also at higher risk for developing cardiovascular risk factors, including hypertension, type 2 diabetes, hyperlipidemia, and CKD. And when we account for some of these risk factors, we find that their long-term cardiovascular risk is actually attenuated, suggesting that some of the risk is mediated by the accumulation of these risk factors in the postpartum time period. I'm going to use this diagram to try to explain this cardiovascular risk assessment postpartum period and why we think it's so important. If you look at this diagram and think about the time on the x-axis and some kind of vascular dysfunction or susceptibility on the y-axis, the aqua line are healthy individuals, and the red line are women with higher cardiovascular risk. And the green line is the clinical threshold where their risk becomes apparent. And as you can see, early in the life, you might not be able to differentiate a high risk and low risk woman. However, an adverse pregnancy outcome gives us a window of opportunity to identify these higher risk women that even when their pregnancy risk factors might improve postpartum, that their blood pressure and blood sugar might improve postpartum, the risk remains high long term. Now that we have been able to identify an at-risk population, it gives us an opportunity for primordial and primary prevention. And the thought being that if we can do targeted screening, lifestyle intervention, and early treatment, we can modify these risks, the risk for these women, and change their trajectory. The cardiology community has accepted that preeclampsia is associated with increased cardiovascular risk and has placed it within the other risk-enhancing factors. So preeclampsia is now considered a risk-enhancing factor, along with other things that you are probably familiar with, like chronic inflammatory conditions, CKD, hyperlipidemia, family history of premature ASCVD. However, how do you use that information in terms of assessing long-term cardiovascular risk? And the goal would be to have these risk factors somehow incorporated into your 10-year risk assessment, but that does not exist at this time. Other proposed mechanisms is that you calculate the 10-year risk, determine who is borderline and intermediate risk, and then use these sex-specific risk-enhancing factors to try to determine who's highest risk. But this doesn't work in the postpartum period because we cannot use the pooled cohort equation to assess 10-year ASCVD risk in women below the age of 40. You have to be above the age of 40 to calculate 10-year risk. And if you do see a woman who's above the age of 40, her risk will most likely be low, leaving you in a situation where you may not be able to properly identify her risk. So what are the recommendations currently provided by our guideline, by our societies? These recommendations are very vague and differ significantly. Anywhere from these women should be seen within 7 to 10 days in the postpartum period, all the way to advising clinicians to optimize cardiovascular risk factors. So this is very vague, unclear, and doesn't provide physicians with guidance. So what I'm going to try to show you in the next few slides, and using a few cases, is how to assess these women using the 2019 ACC AHA guidelines on primary prevention as a framework to consider these women. So let's meet Miss CV. She's a 36-year-old female, G1P1, who delivered by C-section at 39 weeks because she presented with premature rupture of membranes and then had arrest of descent and non-reassuring fetal heart tones. Blood pressure on admission was normal. Her birth weight, the child's birth weight was normal, and her medical history is significant for migraines, and she also developed gestational diabetes in the 3rd trimester of this pregnancy. Post-delivery, no complications. Fasting blood sugar was normal, and she was discharged home without meds. 2 weeks postpartum, she calls the clinic with a blood pressure of 160/110. If you ever receive this call, remember that maternal cardiovascular risk is highest in the postpartum time period, and preeclampsia can develop up to several weeks postpartum. I just want to mention that a blood pressure of 160/105/110 in the peripartum time period is an emergency that requires immediate attention. I think sometimes when we think about patients in the ED, and if their blood pressure is 180, we often send them home as long as they're asymptomatic. That's not the case in the peripartum time period. If a woman has a blood pressure of 160/110, that is an emergency that requires immediate attention. Also, remember to assess for symptoms in any woman with new hypertension in the postpartum time period. This includes assessment of headaches, vision changes, shortness of breath, orthopnea, P&D, and right upper quadrant pain. So our patient, she did report some symptoms of shortness of breath, orthopnea, and lower extremity edema, as well as a mild headache. And so she was recommended to go to the ED for further evaluation. However, I just want to point out that even if she didn't have symptoms, with that kind of blood pressure, she should be further evaluated. So Ms. CV's admission, her blood pressure on presentation was 169/91. She was stating okay. Heart rate was normal. On exam, she was noted to have 2+ bilateral pitting edema, and her NT-proBNP was 1300. And automatically, you should be thinking of peripartum cardiomyopathy, which the clinicians were. And so they did get an echocardiogram, which showed normal LV function of 58%. She was diagnosed with postpartum severe preeclampsia. She was treated with IV medications to lower her blood pressure below 160 millimeters of mercury systolic. She was started on amlodipine, 5 milligrams orally. Her blood pressure stabilized on oral meds, and she was discharged home with an oral Lasix protocol and amlodipine 5 milligrams. Just in case you are not familiar with this oral Lasix protocol, it is based on a randomized controlled trial that was done here at Penn by our MFM and cardiology colleagues. And what they found was, the thought was that in the postpartum period, we sometimes see an elevation in the blood pressure. And the thought being that some of this may be due to shifts in fluid. And so they randomized 384 women to 5 days of Lasix, oral Lasix versus placebo. And what they found is that in non-severe preeclampsia, they had a 60% reduction in the prevalence of persistent hypertension at 7 days, and had faster resolution of hypertension postpartum. So now women who are being discharged in the hospital with this hypertension, with a hypertensive disorder of pregnancy, are often discharged with this Lasix protocol. So, and it's only a 5-day protocol with 2 days usually completed in the hospital, in case you see this on discharge. So she comes to follow up. She has a follow-up visit with us at 8 weeks post-discharge. And I want to emphasize that this follow-up visit is an opportunity that we should use for cardiovascular risk and risk factor assessment. So what did her 8-week follow-up look like? Her symptoms had resolved, her blood pressure had normalized, and so she stopped amlodipine herself. She's a non-smoker. She denied family history of cardiovascular disease. Blood pressure is normal, BMI is 28, and weight is close to pre-pregnancy weight. So we discussed that preeclampsia increases her future cardiovascular risk, and that AHA's Life Simple 7, we discussed AHA's Life Simple 7 framework for ideal cardiovascular health. We discussed that she can remain off amlodipine since her blood pressure has normalized, but she should check her blood pressure if new symptoms arise because of the high risk of her developing chronic hypertension, and recommended follow-up in 1 year. So that seemed like a pretty good visit. However, I just want to emphasize that there is a few things that you do not want to miss. One is a lipid panel. So we ended up checking a lipid panel in her, and we're very surprised to find an LDL of 203. This was a non-fasting lipid panel, and I want to impress upon you that that is no problem. And that is actually, it's more convenient, more physiologic, and some would argue a better predictor of cardiovascular risk. The times to repeat a non-fasting lipid panel would be if the triglycerides are greater than 400, if you need confirmation that the LDL is greater than 190, and the threshold for hypertriglyceridemia increases from 150 to 175. And so I really want to impress upon you that a non-fasting lipid panel is better than no lipid panel in this small opportunity that we have to risk stratify these women. So how do you use this information? I just told you that we can't, these women cannot really be risk stratified according to our ASCVD risk calculator because they're so young. However, I want to bring your attention to the first breakpoint in this algorithm, and that is that LDL should be assessed because an LDL greater than 190 doesn't require additional risk assessment. It is a class 1 indication for a high intensity statin. So if her LDL remains elevated, she needs to be on high intensity statin. But she's already identified herself as a high risk individual that we might not have captured if we had not gotten that lipid panel. Also, women between the age of 20 to 39 should be considered for statin therapy if they have a strong family history of premature CAD and an LDL cholesterol of greater than 160 over milligrams of deciliter. And so I think this is an important point that there are LDL levels where we would start statins in these women, and we should not miss severe primary hypercholesterolemia. Another opportunity is diabetes screening. So about 50% of women with gestational diabetes go on to develop type 2 diabetes in their lifetime. This is a huge risk and a huge opportunity. Almost all the society guidelines recommend screening for type 2 diabetes if a woman has a history of gestational diabetes. The frequency is not clearly outlined, but I think if they are at significantly higher risk, once a year seems like a reasonable time period to continue to check. And even if you don't see these women immediately postpartum, long-term. You should keep this in mind that these women are at high risk for developing long-term diabetes. So in this postpartum window of opportunity, don't forget lipids and don't forget diabetes screening. Let's meet our next patient, Miss AM. So she is 38, G1P1, who delivered by C-section at 39 weeks for gestational hypertension. The remainder of her postpartum hospital course was unremarkable and her blood pressure quickly improved. She was enrolled in Heart-Safe Motherhood for postpartum blood pressure monitoring. And in case you are not aware of this very innovative program, Heart-Safe Motherhood is a text-based postpartum blood pressure monitoring program that was created by our MFM colleagues. And what they have found is that if these women are given a blood pressure log as well as they're enrolled in this texting program, they are reminded to send in their blood pressure readings and they receive feedback based on their blood pressure levels. And what they found is that they were able to reduce readmission rate and increase postpartum visit attendance. So a lot of these women are enrolled in this program. If you hear the term Heart-Safe Motherhood, this is what they are talking about. So she comes to follow up about 12 weeks postpartum in clinic for cardiovascular risk assessment. So she's feeling well, no symptoms. She reports that her father had coronary artery disease, blood pressure is 140/88 and improves to 135/87 on repeat check. Her BMI is 37, so consistent with obesity. And so we discussed that preeclampsia increases her future cardiovascular risk. We discussed Life Simple 7 through the AHA framework, and we order a lipid panel and A1C like we discussed, and we asked her to follow up in a year. Is this a good visit? What I would argue is that there's some things that we should not miss in her as well. In addition to the screening, we should not miss this opportunity to diagnose chronic hypertension and optimize blood pressure control, and to further assess her family history and make sure she doesn't have a family history of premature coronary disease. So what does blood pressure postpartum look like in terms of recovery? So a woman who has developed a hypertensive disorder of pregnancy, normalization of blood pressure depends on many things, especially BMI and race. And for this woman, she was non-Black and her BMI was greater than 35. If you take the women in this study of similar ethnicity and weight, only about 45% of them have recovered their blood pressure at about 2 weeks postpartum. The thought being that about 12 weeks postpartum, most of these women should resolve their blood pressure. In reality, about 80% normalize their blood pressure and about 20% go on to develop chronic hypertension. After about 12 weeks gestation, you should no longer be thinking that this is a hypertensive disorder of pregnancy, rather start considering that this is a patient with likely now chronic hypertension and be treating accordingly. There are a small minority of women who will go on to recover their blood pressure, but at about 12 weeks gestation, you should be thinking about long-term blood pressure management in these women. So 130 is the new 140. You probably are all aware that hypertension is now diagnosed with a blood pressure above 130/80. Stage 2 hypertension, and that's stage 1 hypertension. Stage 2 hypertension is a blood pressure greater than 140/90, and treatment is the same as before. For stage 1 hypertension, now the recommendation is to divide is to further risk stratify based on the ASCVD risk score. If your ASCVD risk score is greater than 10%, you should consider pharmacologic therapy. And less than 10% ASCVD risk score is treated with non-pharmacologic therapy with a goal blood pressure of less than 130/80. However, we just talked about the fact that a majority of these women are going to be in the low risk category. And so what do you do for them? There is a new AHA scientific statement that came out last year, which offers new suggestion for management of stage 1 hypertension in women who have a low for all patients with a low ASCVD risk. So the thought being that if lifestyle modifications don't work, you now can consider pharmacologic therapy in these women. I think really using this opportunity, especially in high-risk women with strong family history of heart disease or other multiple risk factors, to really consider optimizing their blood pressure control early in life. So what are the medications that you can use safely in a woman who's lactating or postpartum? This diagram shows the first column is medication safe in pregnancy, and the third column are medication safe in lactation. And I've highlighted with the arrows the medications that we most commonly use, including labetalol, nifedipine, amlodipine, and sometimes hydrochlorothiazide. But really here our practice pattern is that calcium channel blockers, especially dihydropyridine calcium channel blockers, are usually first-line therapy during pregnancy and postpartum. So we talked about blood pressure control and also family history. It's really important to assess for a family history of premature cardiovascular disease. And that is a first-degree relative with cardiovascular disease before the age of 55 in men and before the age of 65 in women, because this identifies a higher risk group than someone who has a family history of cardiovascular disease later in life. So again, the postpartum visit is a window of opportunity to assess lipids, diabetes, blood pressure, and further define family history, identifying a high-risk cohort. I'm going to bring this all together now with my last patient, Miss SW. So she's 31, G2P2, who delivered by C-section at 33 weeks gestation for superimposed preeclampsia. Her medical history is significant for type 1 diabetes diagnosed at age 16 and chronic hypertension diagnosed at 18 weeks gestation. So we talked about earlier that the 20-week mark helps us distinguish between chronic hypertension and maybe a hypertensive disorder of pregnancy. So her blood pressure elevation began before 20 weeks, so she was diagnosed with the chronic hypertension. Delivery was fine, but postpartum, she actually developed respiratory failure. The thought that it was due to HCAP. She had a CT chest to rule out pulmonary embolism that was negative, and she had an echocardiogram which showed an LVEF of 49%, but no heart failure symptoms. So suspicion for peripartum cardiomyopathy was lower. Respiratory status improved quickly. She presented to clinic for follow-up for about 4 weeks postpartum. She felt well, blood pressure was normal, oxygen was normal, and her BMI is 32. So we assessed the risk factors that we discussed. I actually got a lipid panel. Her LDL was 221, suggesting severe primary hypercholesterolemia. Her diabetes showed an A1C of 8.5 on insulin. Her blood pressure was well controlled. However, this was on carvedilol and losartan that were started inpatient because she was not breastfeeding and she had a mild cardiomyopathy. And we found out that she has a family history of premature cardiovascular disease with a father who died at the age of 41 from an MI. So this allowed me to see the big picture. I really understood that this woman is at very high risk. I actually reviewed her CT scans that she had done for to rule out pulmonary embolism and found that she had severe coronary artery calcification. Given the family history of an LDL greater than 190, severe coronary artery calcification, and the family history, she was started on statin therapy. We actually sent her for cardiac catheterization because of the severe calcification and the mild cardiomyopathy, and she was found to have severe 3-vessel disease. She was sent for genetic testing and diagnosed with heterozygous FH and was started on a PCSK9 inhibitor. So really you can see how this postpartum time period was a window of opportunity that allow us to really better understand her risk, and hopefully we can change her long-term trajectory. So don't miss the opportunity to screen postpartum for cardiovascular risk and treat. Don't miss the opportunity to implement blood pressure management, whether that's lifestyle or medications. And don't miss the opportunity to educate about normal numbers. A lot of women don't know, and to take a pregnancy history because it is relevant to these women's future cardiovascular risk. Thank you so much. Happy to take questions.
Thank you, Drs. Louie and Sangavi, for those great presentations. Thank you so much for your great presentations. I know we're 2 minutes over. I think that you covered the questions that we got in advance. I think you largely covered some of them. One question was about BNP versus pro-BNP and whether there's any difference in those and how to interpret them. That's, I think, a quick one.
I think both could be used. We generally have pro-BNP available here. So I think that is what we would use in the majority of cases.
And I want to be mindful of time for people. I know people will have to start hopping off for maybe an afternoon clinical session. I think another one quick question was best practices for stopping antihypertensive medications in patients who were started on them for preeclampsia, like so they get discharged on an antihypertensive and you're seeing them, as you said, Dr. Sangavi, like 8 or 12 weeks later, sort of what's the practice? I think you had a case where somebody stopped it on their own.
Yeah.
But how do you sort of generally think about that?
So in general, a lot of these women do stop their blood pressure medications on their own when their blood pressure normalizes immediately postpartum. And then, so if they have stopped it and their blood pressure is normal, I give them, the green light to stay off of that medication. However, if their blood pressure is now elevated, then we discuss again, maybe restarting for a short period of time until we can reassess in a few months. If they remain on the medication and they're seeing us postpartum, and if their blood pressure has normalized, then we discuss stopping it to see if it remains normal. But I give them strict guidance to really monitor. Now that we know they have a blood pressure cuff, they can really monitor their blood pressure with any medication changes. And I always advise them, if you get a new headache, dizziness, really check their blood pressure, because we don't want to miss a new spike in their blood pressure.
Great. Thank you both. I'm going to just be cognizant of time. There's a lot of comments in the chat. Just thanking you both for great presentations. I think this highlights the sort of collaboration that we all need to have together as pregnancy, as you all both pointed out, is a really window into sort of broader health, and sometimes is a signal for things that are, to come later. And so all of us sort of as a medical community being aware of that and sort of being kind of engaged in those conversations and discussions about how pregnancy complications might indicate future risk, but also just being cognizant, as you brought up, Dr. Louie, around pregnancy history and how that might make you think differently at, the 6-month mark in the emergency room or in the primary care office, I think was hopefully very helpful for people. And we'll certainly send out the recording of this talk and maybe a summary of some pearls. And we really encourage everyone we really appreciate everyone that joined us from across the system, and encourage people to share maybe the recording and even the pearls with other people in your practices and your divisions and departments to really continue to engage and educate people outside of the OB/GYN community, but broadly across the system in primary care, emergency medicine, cardiology, et cetera, around this awareness campaign to try to improve all of our education and collaboration together. So thank you all so much. And thanks again, Drs. Louie and Sangavi, for great presentations. And you can all look forward to an email from us in follow-up.